Welcome to Oncology Morning Commute. Is immunotherapy replacing chemo in the first-line treatment setting for endometrial cancer? Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by educational grants from AstraZeneca Pharmaceuticals and Merck Sharp and Dome. In this episode of our three-part series on endometrial cancer, Dr. Bradley Monk and Dr. Bhavana Pothuri continue their discussion by turning to some of the ongoing, and some may say groundbreaking, clinical trials for the use of immunotherapies in the first-line setting. Information about the faculty and disclosures can be found at morningcommutepodcast.com/endometrial4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Monk is a professor in the Division of Gynecologic Oncology at the University of Arizona College of Medicine and the Creighton University School of Medicine in Phoenix. He is also USA Director and Principal Investigator of Community Research Development at the Honor Health Research Institute in Scottsdale, Arizona, as well as Vice President and member of the Board of Directors of the Gynecologic Oncology Group Foundation and co-director of GOG Partners. Dr. Pothuri is Professor of Obstetrics and Gynecology at the NYU School of Medicine, the Medical Director of CTO Perlmutter Cancer Center, and the Director of Gynecologic Oncology Clinical Trials at NYU Langone Health Perlmutter Cancer Center in New York City. I am your host, Candace Hoffman. Dr. Monk will begin our discussion.
Greetings and welcome. My name is Brad Monk. I'm really excited to talk to you about some of the nuances in the treatment of endometrial cancer. Probably the fastest pace of discovery in gynecologic cancer. As you know, we got an accelerated approval in ovarian cancer recently, but it had been 2.5 years since we had anything approved in ovarian cancer. In fact, we have been losing PARP inhibitor indications for reasons that are beyond the scope of this presentation. So I'm Dr. Bradley Monk here in Phoenix, Arizona. I'm joined by Dr. Pothuri. Dr. Pothuri, Bhavana, say hello.
Yeah, hi, I'm Bhavana Pothuri. I'm a GYN oncologist at NYU Langone and Perlmutter Cancer Center, and I'm excited to be here with Dr. Monk to talk about some advances in endometrial cancer treatment.
That's great. So we have a number of immune checkpoint inhibitors under development in endometrial cancer, but we also have 3 approvals. And let's sort of walk our way through that. The approvals are currently in second line and are informed by the molecular signature, specifically MSI-high, which is definitely probably the most predictive way to determine what the appropriate treatment is. This journey started with probably the largest basket trial in solid tumor oncology, which is KEYNOTE-158. One of their baskets was MSI-high or mismatch repair deficient endometrial cancer. That study enrolled 79 patients, reported by Dave O'Malley in the Journal of Clinical Oncology in 2022. And of those 79 patients, there were 48 responders. In fact, within those 79 patients, there were 13 complete responders. So that's a confidence interval between 37 and 60%. But it was really exciting, led to FDA approval. Remember, we got accelerated approval, agnostic of cell type, but ultimately this completed the full approval, and now this has regular approval since March. So that's pembrolizumab, a medication that you all are familiar with. Tell us about the recent approval of dostarlimab and outline the Garnet study. I know a trial that you participated heavily in, Bhavana.
Yeah, so Garnet was a trial that included a arm, which was A1, and that looked at endometrial cancers. And within that, there was a mismatch repair or MSI endometrial cohort that looked at 143 patients. And then there was also a mismatch repair proficient cohort of 156 patients. And this was recently reported The response rate, the overall response rate was 46%. And this led to FDA approval in April of 2021. This was an accelerated approval for patients with deficient mismatch repair recurrent endometrial cancer. And then August of last year in 2021, dostarlimab also received approval for any adult patients with DMMR recurrent or advanced solid tumors. So really broaden that approval category. And so now we have two checkpoint inhibitors, both pembrolizumab and dostarlimab, that are approved for patients in the recurrent setting.
And patients need options, right? So I like it that there are two. One of the things that I was very impressed in your hard work on Garnet is that it also led to approval in Europe. It's pretty rare to have a single arm trial get approval in Europe. There's some examples, let's say cemiplimab in squamous cell skin cancer. But this got that done. And so it brought the medication to people ex-US. And I was very impressed by that. As part of the confirmatory trial within the US, we did a study called Ruby. It was a GOG European network collaboration, very ambitious to really move the ball forward and improve upon the standard carboplatin paclitaxel that we use in metastatic or recurrent endometrial cancer. And we did that study. And as you know, on December 2nd, there was a press release that it actually worked. So this will be a game-changing study. Tell us about that press release, Bob. And I know this is something you're very passionate about.
Yeah, it was what an incredible day, really, to hear this. So I am going to actually read the press release. So this was issued by GSK, Jemperli or dostarlimab Ruby phase 3 trial result meets its primary endpoint in a planned interim analysis in patients with primary, advanced, or recurrent endometrial cancer. Results showed a statistically significant and clinically meaningful improvement in investigator-assessed progression-free survival. Ruby is the only first-line trial to show improvement in progression-free survival for an immuno-oncology therapy in combination with standard of care chemotherapy in primary, advanced, or recurrent endometrial cancer. The regulatory submissions based on the trial results are planned for the first half of 2023. So really, really exciting. I'm going to read one more line. The trial met its primary endpoint of investigator-assessed progression-free survival. It showed a statistically significant and clinically meaningful benefit in the pre-specified mismatch repair deficient DMMR microsatellite high patient subgroup and in the overall population. A clinically relevant benefit in PFS was also observed in the mismatch repair proficient MSS patient subgroup.
I love it that you read it because it's a complicated message that's very carefully worded. I think it's the only way to sort of tell people what the results are because that's all we know. That is all we know. And so in the DMMR subset, it prolonged progression-free survival. And then ultimately they pivoted and carried the alpha forward in a hierarchy intent to treat analysis. And then what about the PMMR? You said, well, it's clinically significant. So what percentage of patients are DMMR, would you say?
So about 20 to 25% are DMMR. So the majority are your MMRP patients.
Yep. So mismatch repair proficient to non-MSI high. So I think one of the things that I'm really interested to see is how much of the difference in DMMR was really influence in the intent to treat analysis. In other words, maybe the intent to treat analysis is driven really by the dramatic effect in the DMMR subset. So there's a similar study where the DMMR patients are actually carved out and managed differently than the PMMR. And the DMMR subset in that study is substantially bigger. That study is completed enrollment. That checkpoint is pembrolizumab, and that's GY018. So sort of almost identical studies, of dostarlimab Ruby, but it's a hierarchy, DMMR first carried to intent to treat, where GY018, run by Energy Oncology, also part of the GOG Foundation, is carved out, and that study is completed enrollment. There's another study that's called ATTEND, which is atezolizumab. We just can't talk about every agent, but that needs to be noted. That has about 550 patients and is run by the Mango Group exclusively in Europe with the principal investigator of Nicoletta Colombo. Now tell me about DuoE. DuoE is another ENGOT GOG Foundation, now with our, I guess it's our fourth checkpoint here that we're studying. We talked about pembrolizumab, dostarlimab, and atezolizumab. Tell me what durvalumab does and what's being studied in DuoE, because I think it's really, really novel.
Yeah, no, it's a really interesting study. It's a 3-arm study. It's chemotherapy plus durva with chemotherapy, and then in the maintenance setting. But it's also an arm that adds durva and olaparib. And then the last arm is just with placebo. So this is looking at whether the combination of a PARP inhibitor really, and the idea is, does it increase the neoantigens and really help the immunotherapy work better in a PMMR subset? And so, I think a very novel idea. And I think, I'm really interested in seeing what the results show. And I think, something that's different in this trial was, they didn't necessarily study the PMMR and the DMMR subset separately. So we'll have to see, what the results are and whether they're going to be powered to really look at any subset, because it wasn't necessarily done in a pre-specified manner.
Yeah, I'm really excited about that. I think there's real hope for PARP inhibition in endometrial cancer, particularly in the PMMR subset. I don't know what Ruby showed, but it's probably going to be hard to get better than the amazing results that we saw in 158 in Garnet. And the good news is, if it truly does work in the non-MSI high PMMR subset, which would be Arm C, it would really be great, because it's like you said, it's 75 to 80% of the patients. So that's the high unmet medical need. I sort of look at this like PARP inhibitors, where PARP works in BRCA and HRD, but in the non-HRD they don't work that well. And so this is an opportunity to take that same sort of situation where immune checkpoint inhibitors work very well in mismatch repair deficient tumors, but maybe we can sort of create some synergy here. Tell me what you would expect for the tolerability of combining a checkpoint inhibitor and a PARP inhibitor.
Yeah, I think, first of all, we know that checkpoint inhibitors are really well tolerated in our patients. And, except for the, small subset, like 5 to 7% that have really more severe immune-related AEs, they're pretty well tolerated. And, all of us have, a lot of experience with PARP inhibitors from the ovarian cancer arena, and know that, those are actually really also well tolerated. And we're very familiar with managing the nausea, fatigue, that patients experience. So I think it certainly is a much more tolerable regimen than the approved regimen of lenvatinib with and pembrolizumab, which may be another option, right, for PMMR, even in the front line, if LEAP 001 reads out positive. So I think I'm certainly very excited about DuoE and really the ability to potentially benefit that PMMR population that we were talking about.
I love that segue. So every patient in the second line should get a checkpoint inhibitor, unless there's a contraindication. Every patient.
That's right.
Every patient. And if it's MSI, they can get dostarlimab or pembrolizumab. And if they're not, they can get this pembro-lenvatinib opportunity in study 309, which is the ASI number, or 775, Keynote 775 with the Merck. And so what that adds is lenvatinib at 20 milligrams with a dose reduction to 14, 10, and 8 in patients with PMMR second line. And that was compared to physician's choice chemotherapy, as you know, which was sort of the agreed upon standard. So that was done. That at the first interim analysis was positive. And then ultimately, it was presented at ESMO, an update with an improvement in response rate versus physician's choice chemotherapy from 15% to 32%, an improvement in progression-free survival. But most importantly, now updated because it was the first interim that got FDA approval, final OS with a hazard ratio in the PMMR subset of 0.7 with a 5.8 month improvement in overall survival. Transformational. Now, you told us how checkpoint inhibitors are being added to chemotherapy in the front line. Tell us about this chemotherapy-free option where the same regimen is being studied in the PMMR subset frontline, chemotherapy-free, the same regimen as 775 in second line. And tell us about LEAP 001.
Yeah, so really it's trying to replace our standard frontline chemotherapy based on GOG 209, which is paclitaxel and carboplatin, with lenvatinib and pembrolizumab. And it's a randomized phase 3 trial in the frontline setting, 875 patients. It has completed accrual, and I think we're all eagerly awaiting these results. This could be an opportunity to move up pembrolizumab into the frontline setting in mismatch repair proficient endometrial cancer.
Yeah, you mentioned the adverse reaction. So the way I look at it is this is an oral medication, lenvatinib. Oral medications cause fatigue because they're chronic and GI, nausea and diarrhea. Also, it is an anti-VEGF, and anti-VEGF causes hypertension, proteinuria, and other anti-VEGF related adverse reactions. And then ultimately has the immune therapy, which can cause immune-related adverse events. So you got to sort of juggle three balls. And the lenvatinib, particularly if you look at the 775 study, there were only 29% of patients that did not experience a dose reduction. And quite frankly, most of those patients were rapid progressors. And the number of patients that ultimately could tolerate the third dose reduction, which was 8, remember you start at 20, was only 13%. In fact, the median dose intensity of lenvatinib in Keynote 775 was 13.8. That sort of led people to sort of start at 14, which is the first dose reduction, but we'll have to see. So let's just given that adverse reaction sort of history, which can be managed again through interruptions and reductions and other mitigation strategies. Let's just say that what you talked about, DuoE in the PMMR, durvalumab, okay, and olaparib, but you still need the chemotherapy, or pembrolizumab in that a chemotherapy-free regimen. I don't mean to put you on the spot because it'll depend on the data. How are people going to look at that decision between olaparib, durvalumab versus pembrolizumab in PMMR first-line opportunity? Tough question.
Yeah, that's a tough question, right? But I have my bias, and I think that, the chemotherapy is only for 6 cycles, and then the maintenance is what continues, right?
Right.
And, I don't think people want to be continuing a maintenance therapy that's toxic. So, I just think that the combination of a PARP inhibitor with a checkpoint is much more tolerable than a TKI with a checkpoint. And for that reason, I think people are going to, it obviously, as you said, really depends on the data. But if both are positive, I think patients and physicians are going to prefer the DuoE regimen. But, time will tell.
Time will tell. And as I said, when we started to talk about dostarlimab and pembrolizumab, people like options. The good news about pembrolizumab and lenvatinib, there's no alopecia, okay? And there always is alopecia basically with paclitaxel. So I hope to have another podcast when both of those studies are positive and we can sort of break them down systematically.
Yeah, that would be fun.
Wouldn't that be fun?
Yes.
Now I said in PMMR, in the DMMR subset, you may not need the chemotherapy. You may just sort of it may be sufficient to get pembrolizumab or dostarlimab. The dostarlimab study is called Dominica versus carboplatin paclitaxel in the DMMR subset. Tell us about C93.
Yeah, I mean, before C93, I think the recent dostarlimab data in rectal cancer that was presented at ASCO, I mean, and published in the New England Journal with 100%, complete response in locally advanced disease was, quite impressive. And so it really makes me excited about, our studies that we have utilizing checkpoint inhibitor, the C93 trial, which Dr. Slamovitz is leading, is looking at pembrolizumab versus chemotherapy with paclitaxel and carboplatin in the DMMR subset. And the EN13 or the Dominica trial is a very similar trial, except it's utilizing dostarlimab versus chemotherapy. And that's an investigator-initiated trial and only in Europe. So, but I think these two trials are going to really, really change the entire treatment landscape of DMMR endometrial cancer. And to have a therapy that's so well tolerated and so effective is going to be pretty amazing.
No question. And then what we do when things are looking so exciting, we just go to adjuvant. Because all of these other studies are, measurable disease or stage 4, very high risk patient. But maybe an adjuvant is the biggest opportunity. Maybe we could do that. And that is being done. That study's also completed enrollment. Again, a very, very aggressive opportunity, almost 1,000 patients. And that's another GOG-NGOT collaboration called B21. Again, that's really swinging for the fences, as we say. But I think that's something that we were very excited about.
Yeah, and let's not forget about GYO20 as well.
Yes, tell us about that. I love that.
Yeah. So, and that's looking at the, high intermediate risk DMMR endometrial cancer, and it is looking at radiation versus radiation plus pembrolizumab. And so I think that's going to be a very important study that was done through the GOG CTEP mechanism, and Fleur Bacchus is the PI on that trial, and that's completed accrual. Will probably take a little longer to read out, but given that it's an early stage adjuvant trial, but I think still also will be very fruitful in helping us answer the role in an even earlier stage setting.
Yeah, this has been an exciting journey for me. I graduated from medical school in 1988. That's when the staging system changed. Remember, you probably don't remember, you're too young, but patients used to get radiation before surgery. And then in 1988, they changed the FIGO staging. They said, look, why don't you do an operation and figure out if the patient needs radiation rather than ultimately radiate everyone. And then 2004, 177 was a study, 3 drugs versus 2. 3 was better. Staging system was changed again in 2009, TCGA in 2013, and then ultimately accelerated approval of MSI-high pembrolizumab in 2017. And that was really amazing. And then pembrolizumab came on line 2019, and then now ultimately got regular approval, and now we have dostarlimab. So this is the pace of discovery here, adding to chemotherapy, understanding biomarkers, and ultimately evolving to a chemotherapy regimen. Those 3 things are sensational. So I want to leave you with the last comment here, Bob. Now, this has been very, very enlightening to me and exciting. Congratulations again on the Ruby result. The cupboard is full. We'll see what these other studies show, but I'll give you the last word.
Yeah, I just think it goes to show how important clinical trials are and how grateful I am to all our patients, research care teams who really put their heart and sweat into, getting these trials accrued and helping bring these new medicines to our patients. And it's certainly a really exciting time to be in endometrial cancer care. And it's an exciting time for all of us to continue to learn all these therapies so we incorporate them into our practices. It's been great having this discussion with you, Dr. Monk.
You, Dr. Mathuri. And I want to thank you for all you do. I think the currency of being an investigator is enrollment, and you're one of the leaders. And not only do you enroll Caucasian patients, but quite frankly, every patient that walks through the door is a candidate in your mind. And you live in a very diverse part of the country, being New York. So thank you to our audience. Thank you for joining us. Hopefully this has been productive. So long for now.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/endometrial4. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.